Okay, great. So, welcome back after our first break of the afternoon. Last break of the afternoon.
We're not back. Wait, hold on one second. Do they count us back?
He has to tell them.
Studio, you want to count us down? They're on? Okay, all right, they're on. Never mind. Good. Go ahead, sorry.
Are we
trying?
Recording in progress.
Okay, everybody. So we're going to get started in our discussion session. At break, I heard lots of rave reviews for our presenters addressing the opportunities and challenges that we face in delivering in this new era of disease-modifying treatments. How are we going to approach this? So there are a series of questions, and what I'd like to do is just set the ground because we are short on time. And I think we have a hard stop at 4 p.m. for public comments. 4:05. Good. So we have all of 20 minutes for discussion. And what I'd like to do is do some rapid fire question and answers. So I'm going to be militant about my enforcement of time. So you can ask, if you have a question, you can ask a question. You cannot make a statement unless you're asked a question. Question should be 30 seconds plus, please. And responses should be very direct. And once we get the range of questions, then we're going to come back around. I promise to come back around to the big questions. All right. All right. So with that, we'll get started. First of all, anybody here in the room or has a question for our presenters on the topics of the day? Well, I think you covered the topic of the day. Arlene.
Yeah, so all of the issues about workforce and capacity are the same for primary care. So I was just curious about your thoughts about how to really make it feasible for primary care to do this work or co-manage.
That's a very good and difficult question. I think we can probably help primary care more easily in terms of using modern technology to identify people who are worrisome. There's digital clock, there's analysis of patients' narrative over a minute. I think that's the easy part. But once they're identified, I think we're going to need to develop systems where primary care doctors can check in and get additional help, both in terms of expertise and individuals who can carry out simple things that PCP can, so that his or her time is opened up to do what's very
Right on track. I'm very.
Lost my card. But thank you. I can hold it up for me. So I have two questions. One for Ron Peterson and one for the two of you. We both touch on the topic of information and data collection. So for you two who practice in the academic environment, with clinical trials rolling, you mentioned AlzNet, and is that the primary data collection source, or how does that interface with the information you get from your health system, or that you would put into the health system so that it will also support population?
Well, I can start. Or you?
I can start.
Go ahead.
Okay. One thing that we decided to do with all of the effort put into actually delivering care is to start with AlzNet, continue clinical research as it's existed, but have this separate program, kind of like we described, like the way you would like an anticoagulation program, where it's just focused on that, and add on local research. There are labs looking at certain biomarkers of our academic center, but to start with this infrastructure that's national. People may know that AlzNet, as was mentioned, is an Alzheimer's Association national network. So that's adjacent to, but separate from the observational and clinical trials that we do. So it's hard.
And I think we're hoping, because they're very talented people who have done electronic health records, that they will help us take the data that's there and mine it in a way that it moves relatively seamlessly. It remains to be determined whether that will happen. But I think that will make it much more likely, one, that the data will be shared and there'll be fewer mistakes. Every time a human being moves data, there's going to be human error. So.
Thank you. And maybe the other question for Dr. Peterson, which also has bearing, I think. So, very elegantly in his health system, he was able to identify people who might be, who are eligible, but also, so how capable, to what extent is the health system in different localities capable of identifying people in that way, right? Who have a impairment and to be able to assess relative or potential eligibility. Just curious about the system's capabilities across the country.
Well, thanks, Sherry, if that was intended for me. Yes, I think we can take our health system, and we use Epic like many health systems use these days, and we can probably develop an algorithm for individuals that would qualify for this therapy, be eligible for this therapy, and at least in our hands, might exclude them and generalize that to the general health record as well. So we use the electronic health record to cull the people down as to who might be eligible for this. So I think this can be integrated into electronic healthcare records.
Thank you.
I'm just going to point out that's one group we talk about that's not here is electronic health, that kind of healthcare system, electronic databases, and their role in this process. So it's a great key.
Just a really your point, quick hit. You had some barriers in your presentation. What would you say are the top barriers that are ripe for quick change in order to facilitate implementation of CMT?
Hiring and training of advanced practice providers to leverage expertise and pass it on to individuals who are very capable. I think that's the most significant thing that we're working on. And perhaps other people to help coordinate. Patient navigators and things of that sort. We're not sure who's paying for that. But it would be really helpful for patients to have go-to people who can help translate things and come to clinical staff with these issues. Very.
I was going to say the same thing. Personnel, human resources, and doing it with us as we embark on this. So it's a learning curve for everyone.
Well, it's an interesting perspective because cancer has a long history with navigators. They haven't, I'm not sure they've figured out the basic model yet. There, at least they had them when I was there 6 years ago. But I think it's a great example of how can you use other models to know where you need to grow.
So, and I'd like to generate your questions, other speakers and other members of the group. So what do you all see as the nearest term? What can be done in the next 6 months, 12 months? We Joe's plea, which is don't let perfect be the enemy of good. Try to deliver for people who can help. What could be done reasonably in the next 6 to 12 months?
So I know it was mentioned at the very beginning by Laura, I believe, we have to involve community-based organizations in human system. But what's the barrier? Why can we not do it right now? That's the question. And one of the reasons is because if you got any symptoms of dementia, if you're diagnosed, you are discharged from adult health center, the place that you used to go to, senior centers, home care. If you've got dementia symptoms, then the private companies providing home care, private companies that are providing adult health center, now it's a liability, so they got to discharge you. So how do you go over that barrier? You want to make it into your payment system. You want to pay them, but they would not want to do it because it takes additional specialists, and it's your liability the moment somebody's got dementia diagnosed. So that's I don't know how it's going to be incorporated into the community.
What stakeholder do you think could influence that?
So from state point of view, it's your policy. If somebody's got dementia, that person is a liability, you better have a specialist, clinical specialist in your personal care home, nursing home, adult health center. But these are typically for-profit organizations. It costs you a lot more to have a specialist, dementia specialist. So you want to discharge the person and get a senior who's more healthier. You don't have to spend as much overhead and money. So there's got to be an incentive from the state point of view, from Department of Health policy point of view. So if you take on dementia senior up to a certain level stage, then maybe you get additional reimbursement. That's just an idea. Same thing with the personal care.
So to build off that in our presentation this morning in this one, our goal is not just to slow cognitive decline, but to maximize functioning and well-being and manage all those other chronic conditions. How is, not to put MGH on the spot, how are you all thinking about providing that care coordination piece and all of those, I don't want to say wrap around, all those other services with some of these pharmacological or disease modifying treatments? And is there an opportunity to deliver all of that together, especially for the 80% that might not be eligible for the treatments that are available potentially soon?
I mean, there's a huge bottleneck in terms of personnel, but we have integrated care. We use social work. We have actually 5 now who participate, and it's really a critical part. We rely on the Alzheimer Association to support our patients. We leverage people by providing caregiver support groups online, and also cognitive therapy for people who are mildly impaired. So memory strategies in some ways, one to many, and people love it. So I think that's what we're doing now. It's not enough, but it is a start.
I was just going to add, I think, to generalize what else like ours do to piggyback on the morning discussions. Like we're evaluating care models now to augment this. So like the care ecosystem model that UCSF has done, the dementia care model, employee health navigators amongst other things. This is again, as we were just talking about, this is another personnel issue, right? So who's covering that? And so I'm really optimistic to hear that is being worked through to figure out how to actually finance dementia care with the great work of that group this morning. So.
I have a question for our industry speakers today. So we've talked about increased representation of participants in research of diverse backgrounds and all, and diverse medical problems from CMS or comorbid issues. And I know that has become more common in recruitment into trials, but how about mixed brain pathology? So if somebody has both amyloid pathology and Lewy body pathology, are the companies moving towards saying, okay, we're going to start having, we have people with mixed brain pathology as well, the vascular and amyloid and Lewy body oriented therapy?
We actually had a program, we still have, at ESI that is looking at patients actually with Lewy body dementia. But this is completely a different program that we have. So these are not run actually together, but as separate programs within ESI. And there has been actually some publications, at least it was a phase 2 study that was published a while ago. And we keep actually going with this, but we never actually mix the indications, but we look at them separately.
Yeah, I mean, the same applies to Biogen. You may have heard about, we had a program called Rostromatab looking at cortical-basal degeneration that didn't quite go anywhere. But having said that, the focus remains on neurodegeneration, but trying to keep them separate.
Yes.
Obviously, we're also focused on tau. We released data on our BIV80 program at the recent meeting, but again, the future is we're exploring opportunities to combine therapies because we do know that the pathology in the brain is, it's not just amyloid, but we're not quite there yet.
Even to use anti-amyloid therapy in a mixed pathology.
Yes, we have it. Yeah. We talk about it all the time, but the thing is, how do we get to a clear enough enriched patient population so you can get signals in terms of how can we measure clearly markers of clinical improvement, patient outcomes, etc. So I guess what we're trying to say is we are open. to talk to our stakeholders who may know much more than us to say, okay, what do we need to do?
So to follow up on your question. So my understanding is that in the population's open trials, diagnosed folks, about half of them have Lewy bodies and cognitive pathology. So the population that is being studied is pathology. But I was intrigued by CMS's discussion earlier about comorbidities. And I watched the distribution that was shown for the CMS population versus the clinical trial population. And there was a fair amount of overlap between 2, 3, 4 comorbidities. But there was less overlap, 5 plus comorbidities. So a question for, and correct me if I'm wrong.
No, we actually looked at this
question. How will we address the question that CMS is raising about the impact of comorbidities?
Actually, I had the data from CMS, and we looked at the data. And when you're looking at, you're going to be surprised that within that age group, you don't see any difference in terms of comorbidities or co-medications as compared to a general population with that age. So that is completely actually, it's not a unique patient population that you're dealing with. It's just an aged population. And that was something that, we wanted to demonstrate actually with, and we shared with CMS as well, that when you're looking at the patient population, forget about actually the diagnosis. Look at the entire patient population within CMS. And when you're looking at that age group, these are the comorbid conditions, and this is the patients that we identified. Not, of course, using amyloid confirmation because we don't have that information within CMS, but we looked at patients with a certain diagnosis that they had. And we even actually looked at MCI, which is not unique to AD, but MCI general, and also AD population separately. And you can see that these actually, they overlap completely. There is no difference.
So I'm back to your question, Randy, about what's the one quick thing you could do? And it made me think of Joe's comment and the perfect not being the enemy of the good. And this isn't a very sharp observation, but I'm still not clear what the good looks like, right? So I'm not worried. If I understood what the good looked like in terms of how do we use these medications in a way that keeps our patients, keeps people safe, and gets most of the folks who can benefit, some of the folks who can benefit, but also keeps folks safe, then that's the good, I think. And I'm not. I felt like you guys are starting to get close to that in your implementation, as you outlined it at Mass General. I don't know if that's.
Can I clarify your point though? You're explaining that you don't know what the good looks like from a outcomes in a clinical trial, or you don't know what good looks like with implementation?
From an implementation standpoint, using a primary care lens, seeing all comers come and thinking about how do we at that funnel issue. Yeah. And maybe you can speak.
I think that it's moving forward with the idea of as you go.
Yeah.
I think our stance and I think general principles are to be very conservative initially, limit, try to extend the web of potential referrals, but be conservative when it comes to determining eligibility. And then be very attuned to growing with our health system. I think what it looks like is sort of bumbling through together initially, right? As opposed to having a start ready for you. It's just another analogy to mind is, I was talking to someone earlier about take multiple sclerosis and neurology, which was kind of where we are many years ago with other disease-modifying therapies that are effective. Those are still in the hands of subspecialists within neurology, right? And so the scale of this disease is 10x times the amount of MS or more. I don't know the numbers, but the idea is that we don't know where we're going to be. Are we going to be in the hands of specialists in 5 years? But can't really. For now, we need to be. Some thoughts, right? And we need to scale that out.
You're really talking about a learning health system. Doing this within the context of a very very deliberate, very intentionally built learning health system.
Randy, may I comment on that? Bruce, that's a great question, and I think I agree with Seth that we need to start out slowly here in somewhat of a conservative arena, such that we learn how to use these drugs, we learn what the real risks are, and then generalize from there. But I think initially the good is going to be using these drugs in somewhat of a restricted setting.
Ron, you want to expand on that? What restricted setting are you thinking?
I think in the hands of specialists initially. I think that what Kirk and Seth were outlining is an appropriate approach to roll these drugs out in the hands of people who have some experience with them, so that we can manage patient safety and also see if in fact the drugs are effective at what they're supposed to be doing. So I think that's the realistic way to roll these out. And like Seth was just saying, that's what they did with MS. You know, it still was the specialists who are the ones who really knew how to use these drugs. And I think that's in the best interest of the patients as well.
Mine was going to kind of take a right turn, kind of back to science itself. We're talking about aging populations, but we've got a huge population of young onsets that we're seeing. And they haven't been given as much focus in this process. You know, we talk about all the comorbidities within CMS and how we're matching up with that and is that making an effect. But we also have physically healthy individuals with young onset who, or prodromal stage, that, you know, what other factors, you know, yes, I come from the Lewy body world. So, you know, 20 years in advance, I had a brother in his 30s with sleep disorder. We don't necessarily see that in the same fashion in AD, but there are precursors that we be watching for. So how does that fit in? Because they have, because they're wage earners, they reap the highest benefit from these.
I agree, and one point we didn't get to make is that they fall out of the Medicare and Medicaid population, right? And so we have to make sure that we ensure adequate access and coverage to an extent. And I don't know enough about health finance to know how that's going to work. Maybe that's an open discussion for actually access and coverage for those not younger than age 65. It's an open question. Clinician researcher who doesn't know more about it.
Randy, again, if I may just interject here, with young onset people, and many of the folks in the room know this better than I, there may be other components that may actually predict what's going to happen. I'm talking particularly about tau elements. So in the younger individuals, you may need to consider not only amyloid imaging, but tau imaging, because these individuals are more likely to be affected by the tau protein, and with the recent donanemab results, again, bring in some interesting interplay of multiple biomarkers. So we may need to treat the disorders somewhat differently along the age spectrum.
We kind of generalize some of these comments. If the suggestion is that we first start with a selected model where only specialists who know this, you all showed a study by Graham, an institution that delays on the order of years for patients to see. Then if we take this careful, slow, and learn as we go approach, does that then relegate current patients to not receiving treatments so that they're outside the window of treatment and they won't receive treatment? We're saying it's not possible to see that many people this quickly diagnosed and treat them in time, so that within their window of UCI to mild AD, they'll be treated before they move outside of it. Is that the reality?
Yeah, I mean, I think it's a safety balance. This is the big issue, and the decision is, meaning it'll ultimately be up to the system and providers. I mean, I think if people are coming to attention who are in the window of treatment and are aware of the enrollment criteria and have individual discussions with providers, I mean, that's the way medicine works, that's where, in general, I wouldn't be in favor of, being conservative on the kind of criteria. It's more of the expertise knowledge related to delivering it safely. I mean, I think we have to, going back to the prior discussion, we have to open up the channels of referral as much as possible to increase access, but just be wary that it's going to take time to evaluate those folks. I mean, it's a balance. It's a balance.
Let me get some other stakeholders.
Yeah.
I'm running short on time. I get a few other people comment on this just so that we can have that opportunity. So, Sherry, CMS.
So I want to go back to something that was said, about age categories. So you have to remember Medicare largely is by age, but also covers a couple of other categories, which are of younger age. But that means you come into Medicare by way of disability or end-stage renal disease. So, it's still an imperfect fit if you just require, just to limit what we're talking about to Medicare, right? I will also say, though, given Ron's comment about Tau and the interest in how this all intersects, so the current coverage decision to CBD, as long it can be applicable as long as the study addresses amyloid therapy. It does not say amyloid therapy alone, right? It can address amyloid, Tau, as long as the questions are answered. And just to put that out there, that, there may be interest in looking at interactions or other opportunities that are not within just amyloid. So I just wanted to mention.
Thank you.
Yeah.
Okay, I think we're at time for public comments. So I'm going to thank all the speakers and everybody for sharing input on this. We'll continue the discussion, and I'd just like to end on the note that we should all be brainstorming again about how do we beat that curve, that 5-year delay curve for delivering treatment. What can we do to improve that amongst all the stakeholders?
Right. Yeah. So thank you again, Dr. Bateman, for leading that discussion, and for all of our speakers. Again, we really appreciate it. So we'll move into public comments next. I'll turn over to Helen to lead that, and then we'll have some wrap up after our public comments, which are important. Thank you.
All right. Thanks, everyone, and thanks to our public commenters for joining online and being patient as we went over. We really appreciate you joining us, and we are eagerly waiting to hear what you have to say. We have a few in person today and a few online, so I'm just going to call folks out alphabetically and let you know when you're on deck to speak next. It's helpful if you put yourself on video, but you don't need to. And there's one comment that I'll be reading. So our first comment is from Laura Cohen, and the second one is from Candace DiMatteo, if I got that right. So Laura, if you would like to unmute.
Great. Can you guys hear me?
Yeah.
Yes.
Perfect. Eli Lilly and Company believes that amyloid plaque targeted therapies represent the potential for meaningful change for people living with Alzheimer's disease. However, the potential benefits of amyloid targeted therapies may only be realized when patients have timely and equitable access to both diagnostics and therapeutics. Last week, Eli Lilly announced top-line results from our phase 3 trial for our amyloid plaque targeting therapy, donanemab, and they were positive, showing reduction of amyloid plaques, a hallmark of Alzheimer's disease, and slowing of disease progression compared with placebo. This is exciting news for the numerous patients and families affected by this devastating disease. We will continue to work with the Food and Drug Administration to evaluate the fastest pathway to make this potential treatment option widely available to those patients who will benefit. It is time for CMS to revise its April 2022 national coverage determination that severely limits patient access to this new class of Alzheimer's disease drugs. In its current form, this NCD directly interferes with Goal 1 of the national plan, which is to prevent and effectively treat Alzheimer's disease and related dementias by 2025. Without timely reconsideration of the NCD, CMS is leaving patients without access to FDA-approved medications, which is an unprecedented situation. CMS itself has stated publicly that they would reconsider the amyloid therapeutic NCD when new evidence becomes available. An abundance of evidence sufficient to trigger reconsideration now exists. That evidence includes Lilly's positive top-line results for donanemab and the FDA's accelerated approval of a second drug in this class earlier this year. Time is of the essence for patients when it comes to CMS action on reconsideration. It can take up to 9 months or more for CMS to complete the reconsideration process. And the longer that CMS waits to open reconsideration, the more early stage Alzheimer's patients, an estimated 1,000 to 2,000 per day, will transition to the moderate stage of the disease and no longer benefit from this class of medicines. We urge the Advisory Council to work with CMS to open the reconsideration process post-haste. Alzheimer's disease patients deserve access to FDA-approved therapies with positive confirmatory data, especially given the fatal nature of the disease and the high unmet need in Alzheimer's disease. Thank you so much.
Candace, and then Rob Eggy. Candace?
Hampus Hillestrom, you mean? I'm online. Is it for the public comment for Hampus Hillestrom?
No, we're Candace DeMatteis from the Partnership to Fight Chronic Disease. What? Sure.
Hi, this
we'll
is
turn to
Candace.
Rob.
Can you hear me?
Oh,
I'm
there
sorry,
she is.
Candace.
There she
This
is.
is Candace.
Yep.
I'm sorry. Okay,
No problem.
thank you so much. As you mentioned, I'm the policy director for the Partnership to Fight Chronic Disease. Since the first national plan to address Alzheimer's disease was published in 2012, the ambitious goal to prevent and effectively treat Alzheimer's disease and related dementias by 2025 has been a major focus. In 2012, the main roadblock was the science. In fact, some researchers criticized the goal of 2025 as too ambitious at the time. Now we do have treatments that delay progression, and we have a rich pipeline of research that promises more, making that ambitious goal a reality within our reach, but only if people have equitable access. The major problem is not a lack of science needed to unlock the mind to treatment. The problem is unlocking the minds of people at CMS who are blocking people's access to the first ever FDA-approved treatments for Alzheimer's that actually interrupt disease progression. The national plan did not anticipate the erection of barriers to access by Medicare when setting these goals. And why would it? Treatments decades in the making, evaluated and approved as safe and effective by the FDA, that delay progression of illness are being celebrated widely among physician experts, including many here today, as well as ordinary people dealing daily with this cruel, fatal illness. Yet Medicare's actions to restrict coverage and erect access barriers are a significant blow to meeting the 2025 goal and goals to eliminate disparities. As you move forward, we urge you to encourage the Biden administration to reconsider its decision to require coverage with evidence development that's blocking access and delaying progress. In the course of today's meeting alone, 2,000 people, more people, will progress beyond the reach of these new treatments. The national plan's goals are not met by our being able to prevent or effectively treat Alzheimer's disease and eliminate disparities, but on our ability to actually do those things and actually doing those things. Thank you for your efforts to make that a reality.
Thank you, Candace. Rob, where would you like to be?
I'll like to right here.
Stand up right there.
Appreciate that. I've worked for everyone else. So thank you for the opportunity to comment. just to make a few quick points here, because I know it's late today. First of all, I think we all recognize, I heard one person say, which struck me, that even from his perspective as an expert on regulatory process here in Washington, been around a long time, this is the most important regulatory decision about reimbursement that's ever been made in the history of the Medicare program. That may be true or not, I don't know, but that was his perspective. From my perspective, it's the most important policy decision this moment in the Alzheimer's space that I can think of. And so I appreciate very much the time that each of you has given to this topic. It demands all that time and much more in terms of getting this right. What's happened is extraordinary. That's our perspective of the Alzheimer's Association. This is unprecedented, as has been said. Even if you look beyond what has happened to date, if you look at the stated plans to continue to regard this treatment, Leqembi, as the next one up, as being not reasonable, not necessary, post-traditional approval, that's yet another step into the unprecedented. We have something approved on the basis of clinical benefit. That would be still under coverage of evidence development because of that determination. So that is concerning. I think the discussion about the balance between risks, and there are on both sides, is right. I like the way thank you very much for the way you framed that, Dr. Bateman. And Joe, thank you so much for your comment. I think that got right to the heart of the issue, that we have to keep patients in mind first and foremost as we think about where do they stand in this process of the balances, and when do they have a voice about whether that's a risk that they want to take or not, as we do in so many other diseases that where we have approved and cover very risky treatments for very dangerous diseases. That's the situation we have here too. So the last point I'd like to make about this is just a little bit more specific on what is level of evidence on this point. I've been around researchers enough to know that if you shift methodologies midstream, it makes researchers very nervous. In this case, we see clearly in the national coverage determination that was finalized, the method that CMS used to reach their determination. It's in a passage where they talk about evaluating all phase 3 trials. And then they have that moment where they say, because none of them have shown non-conflicting evidence of benefit, which they define as slowing progression of decline in cognitive and functional abilities, that therefore this class is not reasonable and necessary. We now have, since that was published in April, a new phase 3 trial that meets the inclusion criteria for that research. That would mean, in my judgment at least, I don't know about others here, that statement would no longer be true, that we would have a phase 3 trial that does show rigorously evidence of slowing decline. But yet we've been told that evidence isn't sufficient to reopen reconsideration. So that's one thing that I don't think we at the Alzheimer's Association quite understand, why the boldness, which we don't mind, but the boldness in this case to intervene and do something so unprecedented is not matched with that same speed to reconsider new evidence when it meets the criteria that's been used to reach that national coverage determination. So thank you very much for the comment. Appreciate it.
Thank you, Ron. Campus Hillestrom, I think you were online. You are next, and then Seth Keller's up.
Thank you so much. Hi, everybody. I'm Hampus Hillestrom, the father of a lovely 9-year-old son, Oscar, who has Down syndrome. Professionally, I previously co-founded and was an executive at an Alzheimer's biotech company, and I'm presently the president and CEO of Lumine IDSC Foundation. Lumine IDSC is a leading national nonprofit organization accelerating Down syndrome research and empowering families with a 300,000 online following. Today, I want to speak to the Council about Down syndrome and Alzheimer's disease. With the triplication of the APP gene, adults with Down syndrome are genetically predisposed to get Alzheimer's 20 to 30 years earlier than the general population. With a lifetime risk of 90%, Alzheimer's is the leading cause of death in adults with Down syndrome. We are very excited that several anti-amyloid immunotherapies were recently approved by the FDA, and more drugs with promising data might follow suit. However, it is vitally important for our high-risk population to have equitable access to these therapies. The first issue is that payers' current eligibility criteria for access, such as age and assessment scales, inadvertently exclude people with Down syndrome. To address this, we've brought together a panel of 20 experts to generate an equivalency consensus statement for adults with Down syndrome that we will share with the NAPA Council in about a month. A second issue is that no adults with Down syndrome were included in the clinical trials of Aduhelm, Leqembi, and donanemab. That represents, for our population, a delayed access of up to 14 years, or almost a whole generation of older adults with Down syndrome. It is now critical that safety trials with these therapies are conducted as soon as possible in adults with Down syndrome. On behalf of the Down syndrome community, I ask the Council for its advocacy in the following areas. Number one, that barriers are removed at the national and state level so that people with Down syndrome have equitable access to these new medications. Second, that NAPA plan updates provide specific supports for the Down syndrome community. And third, that the Council adopts actions towards the conduct of needed safety studies with anti-amyloid immunotherapies in adults with Down syndrome. For my son Oscar, and more importantly, for the thousands of individuals with Down syndrome that are turning 30, 40, and 50 years old every year, please don't disregard our population and do everything in your power to ensure speedy and equitable treatment access to them. Thank you.
Next, we have Seth Keller, followed by Leslie Norris.
Yes, thank you
Seth?
very much. Do you hear me? Hi, well, thank you very much. I'm Seth Keller. I'm honored to be back speaking in front of the council. I am a neurologist, and I'm the co-president of the National Task Group, as well as the past president of the American Academy of Developmental Medicine and Dentistry. And also I help lead as a developmental neurologist within the AAN's effort on neurologic complications in adults with intellectual and developmental disabilities. And the issue that I would speak to in front of the council is the issues of the neuroatypical population, the individuals themselves who basically don't fit within the tight little criteria of normotypical populations, who are able to get the typical assessments in the annual wellness visit or by other neurologists, and the millions of Americans that would fit under what we would define as neuroatypicals. And these are individuals that have difficulties with comprehension difficulties, oral communication difficulties, motor task difficulties, various impediments, including even recognition of visual or auditory difficulties. They're not able to be tested typically in the typical office setting like primary care or myself in my neurology practice. And because of the inability to be able to assess them, we're not able to accurately determine in an efficient way at all whether they even have mild cognitive impairment or dementia. So in that respect, they're basically being excluded in every respect as other individuals. So what was done, because this high number of people, neuroatypical population, we had conducted a panel, the National Task Group ourselves in Lumine IDSC, and great to see campus here. And I was one of the people in the panel serving an expert, and we had created a document called Examining Adults with Neurotypical Conditions for MCI/Dementia During the Cognitive Assessment Impairment. I provide the link. And the neurotypicals that we included in our document: acquired and traumatic brain injury, autism, cerebral palsy, Down syndrome, general ID, those with comorbid conditions like mental health, serious mental deficiencies, illnesses, visual hearing impairments, and the like. And the panel basically found that they were definitely neuroatypical in the sense that there were significant barriers impeding the ability for early detection and assessment. Definitely it happened within the primary conditions. Mass changes in cognitive functioning or in areas where clinicians just really weren't able or knowledgeable to be able to find these nuances with caring for them. And so it really created huge barriers in this recognition, and therefore the ability to form more ability to form testing. The panel recognized that most clinicians had trouble discriminating between current and pre-existing behavioral and functionality, especially in conditions individuals who had long-term cognitive deficits, including definitely Down syndrome and other forms of intellectual disabilities. And the recommendations that we're putting forth would be, number one, broadening federal guidance to include adaptations of assessment practice to accommodate the normotypical conditions. Number two, enhancing education for clinicians about these various neurotypical conditions and how to detect, diagnose mild cognitive impairment or dementia. And thirdly, expanding research to produce more evidence-based information on it being able to assess the normoatypical conditions for later life adult cognitive disease and disorders, and certainly planning for subsequent post-diagnostic diagnostic care, and this is certainly very relevant to all the therapeutics we hope to be accessible one day. Without an ability to assess these normotypical populations, they're basically left out, unfairly denied the ability for receiving accurate and timely diagnosis, as well as being able to get the necessary care and support and therapeutics that they deserve. And finally, the clock is ticking, sadly enough for many, and the house is on fire, and there's so much urgency what's going on in this population. So again, thank you very much for allowing me to give my speech. Thank you.
From Leslie Norris, I'm going to read that one, and after that comment, Russ Paulson. Okay. She writes, Dear Chair and Organizer of the May Alzheimer's Advisory Council meeting, kindly read aloud the following comments. As is required by all reputable medical journals, physicians and scientists attending or submitting papers or comments to the advisory committee must append a footnote disclosing any possible conflicts of interest they have or either received any monies whatsoever from drug companies sponsoring any drug. If there are no possible conflicts whatsoever, the submitter merely notes no conflicts to report. This requirement is not already in force at advisory council meetings. I urge it to be immediately implemented to preserve the credibility of the
Thank you for that comment.
Russ Paulson, followed by Mike and Carol Peterson.
All right. I didn't coordinate with the submitter of that last question, but I did actually start my comments with a disclosure, which is that I have no personal disclosures. I am the Chief Operating Officer of Us Against Alzheimer's, and my organization, as a nonprofit, receives support from thousands of donors, which includes pharmaceutical companies. Thanks for hearing from us today, and thank you to the Advisory Council for taking the time today and for your sense of urgency. It was this council that pushed for a 2025 goal to end Alzheimer's disease, and it's I think still animating this group today, and I think it's at risk. But why is this sense of urgency important? Well, one is Dr. Bateman noted in his review, there is a first goal that says we want to prevent and effectively treat Alzheimer's by 2025. But it's not just that. It's not just some theoretical thing. You heard it from Joe earlier. 2,000 people every day in this country advance to more advanced stages of Alzheimer's disease. And we can't let that continue, especially in the face of having drugs. Dr. Hodes and his team and the pharmaceutical companies have done a fantastic job of the research and development of drugs. Our colleagues at CDC have done a great job of trying to do work on prevention. FDA has reviewed and approved drugs, and now we have a hitch with one agency, which I heard earlier today only looks at the data that's in front of them, but they made decisions affecting drugs they hadn't even seen data for that are still dragging us down today. It's not just those CMS. We all have a part to play. We do at the Alzheimer's Association. They do. We've both stepped up and said we need to move to a world where we have real world evidence collected. And we and the Alzheimer's Association have both agreed to do that. Health systems, you heard from our friends in Harvard Medical System that they've got systems to try to widen the pipeline. They still have issues. I hope we don't spend a lot of time in the phase that Dr. Peterson talked about, where it's just a very small number of clinicians who can treat this disease, because that will keep that 2,000 people pretty constant. We'll be making just a dent in that. So we all need to be as creative as possible in allowing us to meet that 2025 goal. All of us have a part to play. We can't let up. We can't let the quest for perfect data, or perfect interventions, non-pharmacological, or a perfect drug be the enemy of goodness. We need to move quickly. We all have a part to play. Thank you to this council for playing your part.
Thank you, Russ. Mike and Carol Peterson. I think we had to turn your camera off before, so if you want to turn your camera back on.
Is the camera on yet?
It is not.
No, she said you do it, Mike.
You want me to turn the camera on?
Yeah, we are unable to do it from here.
No.
Okay, good.
Oh, there we go. Got you.
Okay.
Okay. Hi, I'm Carol Peterson from Des Moines, Iowa, and I will be followed by my husband, Mike. We are the parents of 3 daughters, and Mia was our middle child. She had Down syndrome and lived a full, independent, vital life. From a young age, Mia was blessed with articulation and communication skills, as well as a personality that made others want to listen to her. Her advocacy work, both independently and with the National Down Syndrome Society, took her across the country. She was impactful. When she was 41 years old, Mia was diagnosed with Alzheimer's disease. 41. She went from mildly forgetful to confused. Mike and I relocated 80 miles to Des Moines near Mia, and the 3 of us moved into a house together. We acquired things: a stair lift, customized wheelchair ramp, specialized van. We made telemedicine appointments when Mia developed a seizure disorder. Mike and I tried to do everything right. We followed a Mediterranean diet, exercised regularly, attempted meditation. We showed Mia pictures of family and friends and talked to her about her amazing life. Our independent daughter became dependent on us for all aspects of daily living. We began to take advantage of hospice services with visits from a nurse, bath aide, music therapist. When advised for safety reasons to stop taking her upstairs to her bedroom, we put a hospital bed in the den, and Mike slept on a mattress on the floor near Mia. We were doing pretty well. But when Mia stopped eating, we panicked, even more so when she stopped drinking. The last day of her life, June 8, 2021, Mia struggled to breathe. With her family by her side and on FaceTime, Mia passed away. It was sad and gut-wrenching, but it was also a relief. Ours is not a unique story because 80 to 90% of persons with Down syndrome will be diagnosed with Alzheimer's disease, most of them early onset. The work NAPA does affects our community, the Down syndrome community, in profound ways. Because there is a known significant connection between trisomy 21 and Alzheimer's disease, we propose that professionals from the Down syndrome community should be part of NAPA Council subcommittees so that we can more readily help each other.
It is very important that people caring for Alzheimer's patients in their homes, it is very common when they're caring for Alzheimer's patients in their home. The children are caring for their parents. With Down syndrome, the opposite is the case. As Carol has shared with you, we were able to provide for Mia's needs in our home. We were old enough to be retired, but young and strong enough for the very physical work of caregiving. That is not always the situation. Many parents caring for their children with Down syndrome and Alzheimer's are significantly older caregivers. The caregiving experience is more likely to be detrimental to the health of the more senior caregivers, unlike what we experienced as the relatively young care providers for Mia. We have a request. Please recognize the full-time nature of older parents caring for their adult children. Provide these caregivers the support they need and respite service. We have additional concerns. People with Down syndrome make up the largest group of early onset Alzheimer's disease. Therefore, it is important for research and treatment studies to include persons with Down syndrome. It is important for clinical drug trials to include persons with Down syndrome. It is important to include professionals with knowledge of Down syndrome in all aspects of the Alzheimer's disease conversation. We appreciate this opportunity to share our thoughts. Thank you very much.
And then we had George Bradenberg was signed up to make a comment, but I don't see him online. Okay. That's it. Any other comments we will get and we will share with you all. Okay, Emma.
So again, thank you all so much for being here in person and online. We really appreciate everyone's contribution to the meeting today. Again, we've really had a good discussion today, and these conversations I know will continue. So again, talking about the comprehensive dementia care models that are out there and the roles that those play, trying to figure out how can we build upon these models to compensate for these new therapies that are coming down the pike. How are we going to pay for these and challenges with coverage? And also making sure that we have the message we hear loud and clear at each meeting is making sure that we hear the voices of people living with the disease and their caregivers and all of them in these unique situations, whether they be parents, people with Down syndrome, young onset adults who have in the prime of life. So again, there's a lot of unique situations, so making sure we get that good representation. So we appreciate the public comments. I think we've talked already that we'll be moving towards disclosure more openly. Even though we've gone through the process with the NAPA Council, we'll be making sure that we are more open about the disclosure and have that public policy in place. So now as we move to close, I just want to remind us that we mentioned before that we will be having, again, NAPA routinely has subcommittee meetings for each of the 4 subcommittees. We will be having our research subcommittee meeting, which is again limited to just those who are part of the research subcommittee. We have invited our 2 representatives from industry so that we can ask them questions, and Mark Cullen as well, I believe. So we'll be inviting people. We routinely invite people to these meetings. They will not be part of our disclosure. According to FACA rules, we will be having our own discussions without their being present. So that meeting will be videotaped and there'll be notes available because of the question about conflict of interest. So on that, I just want to thank everyone for being here today, for great contributions, and we will have our next meeting in person on July 31st. So will be our next, and we will be moving towards looking for new members for the next term. For half of us rotating on, the other half will be on So thank you all so much.
Produced by the U.S. Department of Health and Human Services.